Thank you so much for joining us today. I'm Courtney Gulster with Itiliti Health. We are here with Denis Casaubon and Heather McComas from the American Medical Association and Michael Lunzer from Itiliti Health to talk a little bit more about prior authorization, the new research that was recently released by the AMA, and how it impacts decision-making for payers and providers. Welcome to all of you.
Thank you, Courtney.
Before we get started, I do want to mention that we may not have time for questions today, so feel free to type your questions in the chat and our panelists will reply as they can. And if we need to take your conversation offline after the event, we can always do that. Now, before we dive into some of the research, would the three of you like to start by introducing yourselves?
Sure.
Michael?
Sure. I'm Michael Lunzer. I'm the CEO and founder of Itiliti Health, and appreciate the opportunity to talk with the AMA today and hear their perspective and share a little bit about how Itiliti Health sees opportunities to assist in automating and streamlining prior authorizations. Just a very quick, brief introduction to Itiliti Health. We're focused on assisting health plans with prior authorization solutions that streamline the process between payers and providers. The reason we focus on the payer side is that they tend to have so much of the control and the rules around prior authorizations that we think by assisting payers, we can make the most significant impact on improving the experience for providers.
Thank you. Denis?
I'm Denis Casaubon. I'm a senior product manager with the AMA. I've been there for almost 5 years. I've worked on a lot of items, CPT core product related, as well as kind of the surrounding infrastructure to help make our content more usable. And this is certainly an area where we're focused on multiple fronts. We'll get into that in a little bit, but I have been looking at, in my role, how we can support the move to automated prior authorization and just the streamlining of the process in general.
Wonderful. And Heather?
Hey everyone, I am Heather McComas. I am Director of Administrative Simplification Initiatives at the AMA and our Health Policy Advocacy Group. I've been in my role for about 10 and a half years, and my team works on reducing burdens for physicians and their staff, and prior authorization is at the top of that list of administrative burdens. So this is really important topic for my group as well as our overall physician membership. Prior authorization reform is one of our top advocacy priorities, and it has been for the past several years. And I'll just give a brief disclaimer and say that as part of the AMA's advocacy group, we can't endorse or favor any particular product or solution for prior authorization automation, but we're happy to talk all the time to folks who are interested in working this space and improve things for physicians and patients. So great to be here. Thanks.
Great. Thank you to all of you for the insight. Heather, there is some new research that was recently released by the AMA. Do you maybe want to give us a little overview on what that information is and why it matters?
Yeah, sure thing. So for the past several years, the AMA has been fielding an annual survey of 1,000 practicing physicians, getting their perspective on how prior authorization impacts patients as well as the processes in the physician practice. And so this year, again, unfortunately, physicians reported that prior authorization can really impact care delivery. 94% of physicians indicated that prior authorization can delay access to medically necessary care. And these care delays aren't just about inconveniences. They can actually impact clinical outcomes for patients, which is really distressing. It can lead to patients abandoning their treatment. 3% of physicians indicated that prior authorization can lead to negative clinical outcomes. And I think the most alarming statistic is that nearly 25% of physicians reported that prior authorization has led to a serious adverse event for a patient in their care. That's something like hospitalization, a permanent disability, or even death. So that's a really startling and alarming statistic that indicates that all of us need to work on this issue and make it better for both physicians and patients. From a physician perspective, prior authorization leads to a huge amount of administrative burden. In our survey, practices reported completing about 43 prior authorizations per physician per week. So that's a huge amount of administrative hassle. And it's not surprising then that 95% of physicians in our survey indicated that prior authorization increases clinician burnout, which is a really huge problem in our healthcare system today. And then finally, we also asked physicians about their impact of the process on overall healthcare costs. And the overwhelming majority indicated that prior authorization can actually increase overall utilization of healthcare resources, which is actually, I think, the opposite of what health plans are intending when they create these requirements. And when we think about things, when a patient ends up in the hospital or they decline clinically because of a delay related to prior authorization, that can actually increase overall healthcare costs, which is not what any of us want. So I think the data really, again, make a strong case this year, again, that we need to improve this process.
You highlighted quite a few challenges for payers and providers, and the new regulations that were released in January are aimed at solving many of these challenges. Michael, can you give us a little more detail on how the final rule will change the way that prior authorization works between payers and providers?
So essentially, I think the key initiative here is the new CMS regulations that were published in January of this last year. And essentially what they're expecting or regulating is that health insurance companies, payers need to present an application programming interface that will allow external companies' systems, specifically providers' systems, to access the prior authorization workflow of the health insurance company. And essentially what that regulation requires is three key elements in that interface. The first interface element is the need to be able to share the prior authorization rules with providers via that API interface. Specifically, that specification is called the Coverage Requirements Discovery Transaction, or CRD. And that CRD transaction is there really to ensure that the provider within their systems, we'll use that term broadly, have the ability to know if a prior authorization is required or not. The next transaction is called Documents, Templates, and Rules, or DTR. And within that transaction, the objective is for the payer to be able to give back much more information about what's required for an approval of a prior authorization. And that specification is fairly broad, so it can be anything from very specific questions that the provider's system or provider needs to answer, or it could be more simply a clarification of what documents are required to be submitted for a prior authorization. And then the last transaction is called the prior authorization support transaction. And that's essentially where the prior authorization request is submitted to the payer. There are two ways that those systems, those APIs, can interface. One is a scenario where the provider can purchase or use a third-party tool that interfaces to their EMR and connects directly to the payer's systems. Within this specification, that application is called a Smart on Fire application. And it utilizes a standard interface between that application and the electronic medical record system to talk about and with the data that's necessary to transact with the payer. The challenge with these Smart on Fire applications is that they, with the evolution of the capabilities today, the Smart on Fire applications tend to be dedicated between the payer's back-end systems and a specific Smart on Fire app, meaning that a provider might need to load multiple Smart on Fire apps into their electronic medical record system, similar to loading an app into the phone that you have from an app store. The challenge then, of course, would be that as a provider and you're working with a patient that has a particular payer's systems, you're going to have to work within a dedicated payer's workflow and tool that's embedded inside your EMR system. And the issue then, of course, is that if multiple payers require different Smart on Fire applications, it could be a situation similar to if for instance, your smartphone needed a different weather app for different cities, and you wanted to check Chicago's weather and you needed to use a certain weather app, and you wanted to check Los Angeles weather and you need to use a different weather app. And that, as we know, doesn't make a whole lot of sense. So the way that many of us are promoting the effective use of this type of technology is to have the electronic medical record system, whether that's Epic or Cerner or Athena Health or any of the other EMR systems, perform that integration or that support for these transactions natively within the electronic medical record system. And what that would allow is, as long as the transactions between the EMR and the payers are very tightly standardized, then the provider can use their native electronic medical record system to perform prior authorizations with multiple payers, never having to leave their normal workflow and not having to use any kind of third-party application. So that's Itiliti Health's perspective on this. We'd really like to see the electronic medical record system companies directly support this integration to avoid that uncertainty of third-party applications on the provider side. So I'm sorry about the long narrative there, but I'd be very interested to hear my colleagues on the call and their perspective on this as well.
There was another survey that the AMA recently did that talks about that measures level of provider burnout, and it was interesting that this time it came in that the number of physicians reporting at least one burnout symptom has decreased since the last time they measured. I think that had a lot to do with COVID and whatnot. But the benefit that we're getting is that only about 50% of providers have reported this symptom, and so it's scary to think that half of our physicians are experiencing burnout. And I think, we talk a lot about physicians because we're the physician's powerful ally, but we also view physicians as kind of the canary in the coal mine because all of their staff is also dealing with all this burden. And so anytime we talk about physician burden, we can also assume that there's a lot of staff burden behind it. And so when we think about things like integration versus Smart on Fire app, I think standards usually can do more than clever software. Although a lot of times software is a great answer there, and so it's great to see that there's standards kind of leading the way, and then what software companies do with those standards to implement is really where the rubber meets the road. And so getting that integration piece, if it doesn't ultimately improve the workflow, then it's not a great solution. But what we've seen is that integrations typically do improve the workflow. And so, speaking from an approach perspective, that seems to be definitely the direction that we want to advocate for by way of how do we reduce burden in several ways.
Can you also maybe touch on, Denis, the depth of EMR systems that are available on the market or maybe perhaps coming to market and how that impacts the number of places to submit physicians have?
Sure. So we run a developer program where we issue royalty-free development licenses to companies building new features or software applications that use CPT, and we classify the different types of innovations that come through. And we see a lot more niche EMRs than we expected to see, and I think that is a combination of small practices can't afford necessarily the bigger EMRs. They have more specific needs that aren't always met by the big EMRs, and software is generally more accessible, and so maybe a physician practice can sponsor a new EMR if it's that much better, if there's enough ROI to roll it out. But on the flip side, if we have a lot more of these smaller homegrown EMRs, and Heather can speak to kind of where these may be an issue as well. But if we're seeing a lot more of these EMRs, then we also want to make it clear that these standards apply to everyone, and they can kind of lower the barrier to participating in the interoperable ecosystem.
Heather and Dennis, I'd like to ask a question, a follow-up. Sorry, Heather, in regards to your survey, have you done any kind of analysis or looked at how you feel the new standards are going to align with some of the challenges that providers indicate through the survey?
That is a really good question. And actually, Michael, as you were talking about the different kind of pieces of the APIs, I was thinking about how they're addressing some of the challenges that were reported in our survey data. Over half of physicians indicated that it is really hard to figure out what medical services require prior authorization in the first place. I often like to say that the first Zen road of prior authorization is figuring out what needs prior authorization. Even that piece of it is a burden. It often involves practice staff having to call the health plan and wait on hold to find out if a particular patient is going to need prior authorization for a specific service. So getting that transparency into the EHR, the time of ordering, is really, really valuable. We understand that from a payer perspective, that's kind of the first thing that's being focused on, and it's a lot of work, but we think there's real value there to getting that insight right at the point of ordering, whether or not the physician's going to need to complete a prior authorization for that service. And then also surfacing, as you were talking about, the actual documentation requirements at that time too is really important. Again, tracking down all the different forms that need to be completed these days is really hard. There are different websites, obviously, for every payer. There are different portals that need to be navigated for every single payer. And we hear all the time that the lack of standardization between payers is a huge challenge for physicians. So again, getting a process baked into the EHR, as you were describing, really has a lot of potential, we think, to make things easier for physicians. And also, hopefully, will do a lot to improve the process so it looks and feels the same to physicians and their staff across payers. It's not a different looking animal across every single payer. So we really feel that at least some of these concerns are going to be addressed by the automation, and also just reducing hopefully the amount of back and forth between the physician practice and the payer, and in the reducing the amount of time that the whole process takes, so patients can get the care that they need in a timely fashion, and they're not getting sicker as they wait, as our survey results suggest is the problem right now.
And I would totally concur with your assessment and what your evidence is showing. What we've seen anecdotally with our customers is that a full 20% of provider phone calls can be eliminated by publishing a good quality system that allows those answers to be surfaced quickly. We also found that 30% of all prior authorizations were submitted for things that didn't even require a prior authorization. And then another statistic that we've seen anecdotally with our customers, again, it's a small sample, but 70% of prior auths that are denied are ultimately approved. And the main cause of that is lack of the appropriate documentation. So by giving providers a quick way to know, is a prior auth needed and what documentation is required, we hope to, typically see a dramatic reduction. Our services predominantly have been delivered over portals, through portals, but we also have generated integration with Epic in the new standards, and expect to see some really dramatic impacts when this type of new technology with the Da Vinci interface goes live across the market.
Fascinating to see how this all rolls out, because the adoption for the different pieces will vary, and so it'll be interesting to see if how much is solved by the initial chunks, and what's harder to get at, and how do we approach that. So from my perspective, I just want to encourage more discussion about kind of playing it out through the implementation, between players in the system right now, because there are going to be a lot of challenges and things to work through that we haven't really covered yet.
So thinking about some of those regulations that have recently been finalized, I know that both groups are very involved with Da Vinci and the drive towards creating some more transparency in prior authorization. So maybe we can talk a little bit more about how each of you have been involved in Da Vinci and the recently finalized CMS rule. Denis and Heather, would one of you like to dive into that?
Heather start. She's got the lion's share here.
Yeah, sure. So we have been very involved both in following the work of the Da Vinci Burden Reduction Work Group over the years. We feel it's like really important to get that physician and clinician voice in the development of these guides, so the technology at the end of the day works well for physicians and their staff to serve their patients, which is the utmost importance here. And so I had to give a shout out to my staffer, Celine Lefebvre, who is very active in the Da Vinci work groups and does great work there advocating for physicians, and also has a leadership position at HL7. So that's, we've been very active there. And we've also been very active in advocating with the federal government as these technologies have been both proposed and then finalized via CMS rulemaking. We are pleased with the outcome of the rulemaking process with the CMS prior authorization and interoperability rule that was released in its final iteration in January of 2024. And we think that it definitely has a lot of promise to make things easier for physicians and their patients. And then I also say too, and then something that Michael said maybe kind of teases that in my head, we think the regulation is really important, because ultimately, at the end of the day, I don't think anyone moves until they have a directive to do something. But I think, kind of getting to Denis's point, it is important that we all are ACE students here and we really implement things in the best way possible. We're not doing this to just check a box or make a mandate or, get a, C- and pass. We want to really make this easier for physicians, for health plans, to make the process better so that patient care isn't being delayed. And so I think, really, to Denis's point, like identifying challenges and working on them now and testing and getting those fixed before we go live at the beginning of 2027 is critical. And I think we'll talk about this a little bit more later, but physicians are really, really busy folks, as are their practice staff. And if we implement this in kind of a C- student way, where it really isn't working well for physicians, they're going to try it a couple times and then they're going to get frustrated and they're not going to come back to it. They're going to be like, I don't have time to try to use this thing that doesn't work for me. It's cumbersome. So I think really thinking about how to make this seamless for physicians is critical to make sure that they buy in when this goes live in a couple years.
I think that's a great point, and we're going to circle back to that actually in just a couple of minutes. But Michael, do you want to share a little bit more about how Itiliti Health has been involved with Da Vinci and some of the connectathons and pioneering some of the technology to solve this challenge for payers?
The reality is we're advocating for an effective solution. So much in the line of what Heather said, that our approach is really to make sure that this is a workable standard, and that it includes the elements that are necessary. A great example of that is that the CRD specification, that first transaction is an authorization required, simply requires the answer yes or no. And the reality for a provider is that that's not enough information, right? There needs to be a little bit of benefit insight in that transaction. There needs to be some transparency about policies and rules. And so in that case, for instance, we worked closely with Epic back in the fall of last year. And in January, we demonstrated the CRD transaction at the Connectathon, and it included much more information than just is an authorization required. And so that's the native implementation that we're hoping Epic goes live with in August. That's kind of the stated time we had heard at some point, but obviously I don't represent Epic, so can't quote me on that. But that's the objective really, is to work within that standards group to drive more effective solutions. And so we've been working with with Da Vinci for the last few years to advocate for and work within that standard to develop solutions that work. Another great example of that is within the DTR transaction, there's a concept where the health insurance company can send a questionnaire to the provider that if the provider can answer all the questions, they can have an immediate approval. And that's a wonderful concept if that questionnaire does not add burden to the provider, right? And so the fully fleshed vision for Da Vinci is that the EMR would be smart enough to answer all the questions in that questionnaire immediately. And so there'd be this very fast back and forth. The reality, however, is that we know when this new standard goes live at the end of 2026, there will be many electronic medical record systems that won't be able to automatically answer all those questions. And so it's really important that the payers' implementations not require all those questions to be answered in order to complete a prior auth submission. So the Itiliti Health perspective that we've been promoting is the idea that that questionnaire be equivalent to what the current submission form is that the administrator at the provider fills out. And hopefully then the EMR can fill that out. But if not, at least the administrator that does that function today in a portal can now fill that form out inside the EMR. So a minimal questionnaire rather than a very exhaustive questionnaire that contains clinical information will make that job easier for that existing workflow to be supported for the provider. And then again, a list of the required documents within that DTR transaction that in many cases, those lists of required documents can be coded in such a way that if the EMR recognizes the coding, the EMR can submit those documents or at least surface those documents for that administrator at the provider organization. So again, we're advocating for an evolution of this solution that payers implement such that it delivers positive burden reduction for the provider, as opposed to, if you can imagine, if we submitted a 15-question clinical questionnaire to the provider in that interface, the provider, the actual doctor, might need to answer those 18 questions, and that would be a burden increase instead of a burden reduction. So that's just a little bit of some of what Itiliti Health's been doing to try and advocate for payers and providers. Ultimately, if this solution doesn't work, if people don't use it, then we all lose, right? And so we're all in this to make patients' lives better through that payer-provider relationship.
Does seem like there's an opportunity there. I don't want to disrupt any work that's already in progress. But when the payers came up with their questionnaires initially, there were certain circumstances in place that drove the structure of those. And so it's a good time to maybe reevaluate why the form is the way it is and design an even smarter way to get the information that you really need through these processes.
No question.
How much evolution do you think will happen between now and the beginning of 2027 in how organizations approach prior auth automation? Do you think that that things like the questionnaires will become less of a focus point, or how do you think that will evolve?
My end, I'm not as close as Michael for sure, but when we think about how people have been talking about these different aspects at Da Vinci meetings and offline, it seems like every little topic is a full discussion. And so it does seem to be kind of like an exploratory phase where people are really trying to figure out the scope of each part of the implementation. And so it feels like progress is a little bit slow right now in certain pockets. You've had some great success showing how this can be done. In certain pockets, it's looking great, but as an industry, it feels slow. So it does seem like once people are on the same page with a lot of these small discussions, that there will be an accelerated kind of implementation phase where a lot does change.
And I would agree with that. There's a lot of groups within Da Vinci and kind of subgroups of people talking amongst themselves of how do we perfect each of these transactions to make them work really well. There's also a sense of reality that how do we make them work well at the beginning, as I was talking about with questionnaires, and evolve as the EMR systems evolve, because there is this two sides to this equation, and we need to make it easy enough for the EMR side to work with something that's truly a standard versus kind of where things are right now, which is there's a protocol and there are standards that are fairly high level. And so there are a lot of people trying to get down to the practical matter of how do we make these transactions work among multiple parties so that it doesn't have to be a kind of a one-to-one relationship between a payer and a provider's module that needs to be loaded.
But what's your sense, kind of marrying two concepts here? If we want to say, don't change things for physicians too much because it's going to be hard for them to keep up. But we're also saying there needs to be a lot of change on the back end. How do you think about incorporating changes to how your software works in the back end without having the front end impact on physicians?
Yeah, the first step has been looking at how does the process work today and moving the technology from a portal into an EMR system. A great example of that is the implementation, excuse me, that we did in January with Epic. Their approach is that once the doctor signs the order, then that CRD transaction is sent over to Itiliti Health. We respond back with yes or no, it requires prior authorization and additional details. But the typical workflow for a provider in that scenario would be the doctor's job is done when they sign the order, and now the referral coordinator picks up the workflow from there. And so allowing this new technology to fit that existing workflow at the provider minimizes the intrusion of this new technology in the provider's world. It will also present some opportunities because, of course, at some point it would be wonderful if it was really highly surfaced in front of that doctor to say, what you just did requires a prior authorization, but if you did this other thing, it doesn't. I think that capability and those concepts will evolve. But right now, the critical objective is to get rid of the portal, present the provider with a universal interface, right? And then we can start to improve the provider workflow and really help automate things on the provider side.
So as you've been having some of these conversations on both sides of the conversation, what have you heard being listed as some of the motivations payers and providers have for adopting different solutions? That's an open question for everyone.
I'll jump in first, and I'll just say that payers are very motivated to fix this problem as well. There's a lot of perception that payers create this barrier to reduce cost of care because people will abandon care. And I'm sure there are individuals somewhere that have that perspective, but broadly across all payers, that's not the perception that I get from talking directly with them. They're all motivated to solve this problem. The biggest challenge for them is understanding how, right? what are these standards? How are they going to evolve? And how do they ensure that that they aren't spending a lot of money on things that aren't effective? So they're being very cautious as they wade into this market. One of the interesting things that I see is that a lot of payers are very focused on AI and how that can help make decisions behind the scenes. And we find that the biggest impact for the least amount of money is the front end of this process, solving the problem for, is authorization required and what are the rules and what needs to be submitted. From there, we also see AI is evolving so rapidly here that there are a lot of people looking at it, but still thinking hard about what's the best approach there. So from my perspective, that seems to be the challenge right now, is helping provide payers to see that implementing that front end of the process doesn't take as much deep thought and difficulty as the AI side does, and can have a pretty big impact.
A great discussion between payers and providers around kind of the motivations to adopt solutions. And they were pretty candid saying that payers want to move forward and implement something. Providers are in the same boat. They definitely want to reduce the burden that they experience, staffing shortages, all kinds of issues on their side. But when they go to select something, it's a big lift to incorporate. And if that solution isn't adopted by all of the payers that they work with, then exactly what you were talking about, Michael. It's just duplicate burden all over the place. And so they are hesitant. The provider side is hesitant to adopt something new, and the payer side is hesitant to push something because they know that it's not necessarily going to scale across their hospital sites. So there's a real kind of who jumps first kind of challenge there, and I think it does make it easier if the payers align or agree to some kind of standards and focus on more of the integration path where it's not as heavy a lift to create these things. But that definitely seems like the big challenge to work through.
I just jump in with another thought too. The rule that we've been discussing just applies to government regulated health plans, right? To Medicare Advantage, federally facilitated exchanges, Medicaid managed care, CHIP managed care. And we've had, heard concerns from physicians like, what about all the other health plans? I don't, adopting something that only applies to a certain amount of my patients is, costly, doesn't really make sense. It's not efficient. So, I mean, we are hoping that the health plans will adopt the technology across all their lines of business, whether or not they're required to or not. And we've already heard from some, major national payers that is their plan. And we hope that's true because it will make things a lot easier from the physician side, versus teasing out, is this a Medicare Advantage or a commercial patient, and can I use or not use the API for this patient? That's going to make things really tough for physicians and their staff. So again, I think, I mean, Michael, maybe you could speak to this, but from a payer perspective, it seems like if you build something out, it would make sense to offer it across all your different types of plans because, you're encouraging more adoption. You're essentially getting more bang from your buck for the technology that you've built out.
And yeah, that is the approach we see from payers. They're just as anxious to see the reduced cost and burden as providers are. I think it really comes down to this being a standard or not, right? And while Da Vinci HL7 is a standard, there are different ways that it can be implemented. And so I think back to one of your comments, Dennis, I think the key to moving that forward is the adoption of the EMR vendors, right? We've seen Epic take a very aggressive position at participation in Da Vinci and a few other EMR vendors. We'd really like to see this be more of almost an industry consortium of those vendors deciding on standards because while this can be a competitive advantage for either payers or or electronic medical record systems, it shouldn't be. It should be a common cause that at least if we can agree on some base level standards that we can all connect with, then it's as common as our telephone, right? That we can pick up a phone and call the other side and get an answer. That's really how this needs to work, and it needs to work within the electronic medical record system that way. So that's a big part of Itiliti Health's effort. We've been talking with a number of EMR vendors and promoting a standard way to perform this function, because I think that's what will move the needle. Again, as providers, they want this to be integrated into their system, and they want it to be something that talks to all payers.
Based on what all of you are saying, there needs to be some cohesion between payers and providers on the direction forward. Can you, Heather, highlight a little bit more on the need for provider buy-in on the solutions that you're implementing and how you can assess as a payer how much provider buy-in you have?
Yeah, sure. I think that physicians and their staff's early experience with the technology is going to be key. I think that having really positive initial experiences is really going to be important. Otherwise, physicians are going to get frustrated and they are not going to want to use the technology. And so I think that's going to be really important. And it's not just that the technology is automating maybe the process that we have today, but it's actually improving things. Kind of to Michael's point, this is the opportunity to kind of rethink the way things are done to make it easier, not just turning the piece of paper that you put in the fax machine now into something that's in the EHR, but is there a way to rethink it to make it easier overall? The questionnaire is less detailed. Do you really need all the information? So I think that's going to be really important that physicians have good initial experiences with it. And then I think, the payers that kind of, take attention to that point and make it as user-friendly as possible are going to see higher adoption, across their lines of business. And we think it's really important, as we are looking to 2027 as the big go live date, testing is going to be really key, working with the physicians in your provider networks to test and make sure this works before it has to, because again, if those early months are a bunch of error messages, no one's going to be happy. And, I know it's the same thing if I try a new website or whatever app and it doesn't work right, I'm getting error messages, I give up. And I think that's, we're all human, and that's really important. I think it's also important that physicians have a strong level of trust about the data that the payer is able to access from the EHR, that they feel like unnecessary data are not being exposed to the payer because they take their roles as information stewards and protectors of their patients' private protected health information very seriously. So having that trust that the payer is only taking out the information that they need for the prior authorization is really important as well.
And I know that Itiliti Health has a recommended timeline for implementation that we can share in the handouts to the right of the screen. Do you at AMA also have a recommended timeline that we can share?
We certainly think that we want everyone to be building out and testing right now as early as possible. And I think also communicating various players when they're ready to test, because again, we think that this just goes live, but no one's actually done the testing. I mean, it is concerning. I think Denis kind of alluded to the fact that things seem to be moving a little slowly now. We have like 2.5 years left, and I'm not a coder, I'm not a developer, but to me, it seems like there's a lot left to do. And, I ideally, I'm just thinking off the top of my head, and Denis and Michael's being the more techie people tell me that I'm crazy, but it would be great to have the at least last 6 months, ideally a year of 2026 being testing and, getting out all the hiccups so that things are really smooth on 2027.
Definitely agree. It's a lot to do. So the more communication early, the better, and payers should have a good sense of, how much influence they have with their provider groups. But it doesn't hurt to talk more and to be engaged more in these forums where they can really work out their solutions instead of just doing things in-house.
Yeah, we would highly recommend from Itiliti Health perspective that there are things that can be done in the documentation of rules and medical policies that can be done right now that can impact providers on the portal and can save the health plan money and help the health plan really to be ready for the new interfaces. Because essentially the API is just a new interface. The health plan still needs to have the data in a format. And why not get the benefit of that now through even the portal and improve providers' experience and save provider calls and unnecessary burden while we're all staging and getting ready for the new interface. There's great opportunity to do that now.
Well, thank you to all of you for joining us. We'll be adding some handouts to the right, including the recently released AMA report on provider burden related to prior authorization and the Itiliti Health timeline to implementation to meet CMS 0057. If you have questions, we will also have our speakers' contact information in the as a download to the right. And if you have questions, please feel free to reach out to them. Thank you so much.